Okay, let's dive in. If you are looking at the pharmacology of cancer treatment, you realize pretty quickly you're dealing with one of the steepest learning curves in medicine.
Oh, absolutely. The drugs are incredibly powerful.
Right. And the vocabulary is daunting, and that line between helping and harming the patient feels, well, razor thin sometimes.
It really does.
So our mission today is to give you a critical shortcut. We're diving deep into the core concepts of carcinogenesis.
How cancer starts and grows.
Exactly. And providing a focused clinical breakdown of the cell cycle specific or CCS chemotherapy agents. These are, the real foundational drugs.
They underpin so much of modern treatment, and to set the stage, you first have to grasp the nature of the enemy, right?
Cancer itself.
Cancer is cellular anarchy. It's uncontrolled growth, it's invasion into surrounding tissues, and potentially metastasis spreading elsewhere. So when we talk about these antineoplastic drugs, we have to immediately face the challenge. They have an extremely low therapeutic index.
Meaning that tiny gap between an effective dose and a toxic one.
Precisely. Achieving the therapeutic effect without causing severe toxicity, that takes constant, really meticulous management.
Okay, let's maybe clean up some terms first. Right. Because the definitions here really tell the story. Antineoplastic drugs, that's the big umbrella term, right? For chemo.
Yep, that's the catch-all.
And then malignancy, we define that by its ability to spread its anaplastic, invasive, metastatic.
Which is the complete opposite of a benign tumor. Benign means non-cancerous. It stays put, doesn't invade.
Got it. And tumors get classified based on where they start.
That's right. You've got carcinomas, which arise from epithelial cells, think linings, like gut lining, skin.
Okay.
Then sarcomas, they come from connective tissues, bone, muscle, that sort of thing.
Right.
And finally, the circulating ones, the hematologic malignancies, lymphomas starting in lymph tissue, and leukemias in the blood-forming tissues, usually the bone marrow.
And the type of cell dictates the drug choice, often.
Very often, yes. The mechanism we need depends heavily on the target cell.
Okay, so that brings us right to the core challenge, doesn't it? The cell cycle. If cancer cells are just dividing like crazy, why is it so hard to just stop them? Is the cell cycle even the right target?
It absolutely is, because even though they're chaotic, cancer cells still go through the phases. G0, that's resting.
Right.
Then G1, S phase, where DNA gets synthesized. G2 and M phase, mitosis, where they divide.
But normal cells do that too.
Yes, but normal cells have breaks, really important internal chat points. Cancer cells, they've often lost those breaks. They just keep going.
Okay.
And that cycling is what we try to target. That's why cell cycle-specific CCS drugs are designed to be cytotoxic, to kill cells, only during a specific phase, often the S or M phase.
This is the non-specific ones?
Exactly. Cell cycle nonspecific or CCNS drugs, they can kill cancer cells during any phase of the cycle, even resting G0 sometimes.
So why does this CCS versus CCNS distinction matter so much in practice?
Well, the key to chemo success, especially with CCS drugs, is finding a tumor with a high growth fraction.
Growth fraction.
Yeah.
That's the percentage of cells actively dividing.
Precisely. The percentage of cells in mitosis at any given time. High growth fraction means lots of cells are cycling, making them vulnerable to CCS agents.
But
Yeah.
isn't that also the problem?
That is exactly the problem. The high growth fraction is why chemo works against the tumor, but it's also why it attacks rapidly dividing normal cells. Think hair follicles, GI tract lining, bone marrow.
The collateral damage.
That's the toxic price we pay. It's indiscriminate.
Okay, let's unpack that collateral damage then.
Yeah.
That inability to tell a fast-growing cancer cell from a fast-growing healthy cell. That's the biggest hurdle, right?
Yeah.
Where do we see the effects most?
The toxicities are pretty predictable because they hit wherever cells divide fastest. First, the gastrointestinal tract.
Nausea, vomiting.
Nausea, vomiting, the emetic potential, how likely it is to cause vomiting, varies hugely. Something like vincristine is low risk, but cisplatin, high-dose cytarabine, very high risk. Plus diarrhea, painful mouth sores called stomatitis.
Awful. Okay, GI tract number 1. What's next?
Number 2, maybe the most visible, hair follicles. They divide quickly.
So, alopecia, hair loss.
Exactly. And number 3, probably the most clinically significant and dangerous, the bone marrow.
Right, because that's where our blood cells are made.
Precisely. When chemo hits those blood-forming cells, we call it myelosuppression, or bone marrow suppression.
And that causes...
A triple threat, really.
Yeah.
Leukopenia, low white blood cells, increasing infection risk. Anemia, low red blood cells, causing fatigue, shortness of breath. And thrombocytopenia, low platelets, leading to bruising and bleeding risk.
And this myelosuppression, it often limits how much chemo we can even give, right?
That's often the dose-limiting toxicity. The severity of the myelosuppression dictates the maximum safe dose for the patient. We push as hard as we can, but the bone marrow is often the barrier.
Okay, so if the bone marrow takes a hit, there must be a time when the patient is most vulnerable, a period of maximum risk.
Yes, and that period has a specific name, the nadir, N-A-D-I-R.
The nadir, what is that exactly?
The nadir is the point in time after a chemo dose when the white blood cell count, especially in neutrophils, hits its absolute lowest point.
When is that usually?
It varies by drug, but typically somewhere between 10 and 28 days after dosing. And this is the period of highest risk for severe, potentially fatal infection because the patient is profoundly neutropenic.
So the danger isn't over when the infusion bag is empty. You have to anticipate that dip.
You absolutely have to anticipate the nadir. It's critical for patient safety monitoring.
Speaking of immediate safety risks, we have to talk about extravasation. Can you define that for us and explain why it's such an emergency?
Right. Extravasation is the leakage of a chemotherapy drug out of the vein and into the surrounding tissue during an IV infusion.
Just any chemo drug.
While it's particularly dangerous with drugs classified as vesicants, these are agents that cause blistering and severe tissue damage.
So it's not just irritation, it's destruction.
It's tissue necrosis. It can cause severe local injury, permanent damage, loss of function. It's a true medical emergency.
What's the protocol? Stop the infusion.
Immediately stop the infusion. Don't pull the IV out right away. You might try to aspirate any residual drug back. Then disconnect, elevate the limb, apply compresses as indicated cold or warm depending on the drug, and crucially, administer specific antidotes if available.
Like hyaluronidase.
Exactly like hyaluronidase for vinca alkaloids and etoposide. Prompt action is vital to minimize the damage.
Okay, that's a critical safety point. Let's pivot now from these general toxicities to the specifics of the drugs causing them. We're focusing on the four main classes of CCS drugs. First up, the antimetabolites.
The S-phase killers.
S-phase killers. How do they work? Their mechanism is kind of sneaky, isn't it?
It really is. They're basically saboteurs. They act as structural analogs, false versions of essential cellular components needed for DNA and RNA synthesis.
Like folic acid, purines, pyrimidines.
Yeah, the building blocks. Precisely. They mimic these building blocks. So the cell tries to incorporate them into DNA or RNA during the S phase, or they block enzymes needed for synthesis. Either way, they jam the machinery, halt DNA assembly, and the cell dies.
Can you give us a classic example?
The prototype is methotrexate. It's a folate antagonist. It blocks the action of folic acid.
And methotrexate is where we see that really dramatic intervention, the leucovorin rescue.
Yes, exactly. When we use high-dose methotrexate, which we do to overcome resistance or penetrate certain tissues, we're giving a potentially lethal dose. Purposefully. To save the normal cells, especially in the gut and bone marrow, which also need folic acid, we must follow up with leucovorin rescue.
Is leucovorins?
Leucovorin is folinic acid, basically an active form of folic acid that doesn't require the enzyme methotrexate blocks. It bypasses the blockade.
So it rescues the normal cells.
If timed correctly, yes. It floods the normal cells with the metabolite they need to survive and recover, while the cancer cells, maybe due to slower uptake or different needs, hopefully continue to die from the methotrexate effect. It's a delicate balance.
A clinical tightrope walk, like you said.
Yeah.
Any other notable antimetabolites?
Well, in the pyrimidine antagonist group, capecitabine is interesting. It's a prodrug.
Meaning it converts to the active drug in the body.
Right. And it's given orally, which is a big deal for patient convenience. It converts to 5-FU, another major antimetabolite.
Okay. Class 2, mitotic inhibitors, MG2 phase killers. These come from plants.
Many do, yes. You have the vinca alkaloids from the periwinkle plant, like vincristine, vinblastine, and the taxanes, like paclitaxel and docetaxel, originally from the yew tree.
And they target mitosis, the M phase. How?
They interfere with the microtubules, the cell's internal skeleton, essentially. These microtubules form the mitotic spindle, which is crucial for pulling chromosomes apart during cell division.
So they stop the spindle from working.
Some, like the vincas, prevent the microtubules from assembling correctly. Others, like the taxanes, stabilize them too much, so they form non-functional bundles. Either way, mitosis grinds to a halt. The cell gets arrested in M phase.
Now, vincristine, that one comes with a specific, very serious warning, doesn't it? Neurotoxicity.
Yes, vincristine is notorious for its neurotoxicity. It's probably the most neurotoxic agent in its class, causing peripheral neuropathy, numbness, tingling, potentially muscle weakness.
So why use it?
Because, unlike many other chemo drugs, including its cousin vinblastine, vincristine has relatively little effect on the bone marrow. It's marrow-sparing.
Ah, so it's a trade-off. You accept the nerve damage risk to avoid the severe myelosuppression.
It's always that risk-benefit calculation in oncology.
And there's that other absolutely critical safety warning about vincristine, the administration route.
Oh, yes. This is paramount. Administering vincristine via the intranautical route into the spinal fluid is fatal. It causes ascending paralysis and death, and it's almost always irreversible.
That's terrifying. How is that prevented?
Strict mandatory safety protocols. Vincristine must never be dispensed or prepared in a syringe that could accidentally be used for intrathecal injection.
So how is it given IV?
It must be diluted in a small IV piggyback bag, typically 25 to 50 milliliters, and clearly labeled for intravenous use, only fatal if given intrathecally. This makes an accidental intrathecal injection much, much harder to do. It's a vital safeguard.
Wow, okay. Moving to the third CCS class, topoisomerase I inhibitors. These also target DNA synthesis, S-phase.
Yes, they're S-phase specific. They target an enzyme called topoisomerase I.
What does topoisomerase I do?
Think of DNA like a tightly wound rope ladder. To replicate it, S-phase, you need to unwind it, cut one strand temporarily to relieve the tension, let it rotate, and then stick it back together. Topoisomerase handles that cutting and resealing, the relegation.
Okay.
These drugs, the camptothecins, topotecan, irinotecan, they let the enzyme make the cut, but then they stabilize the complex so the enzyme can't reseal the strand break.
So you get DNA strand breaks piling up.
Exactly. The replication fork collides with these breaks, the DNA shatters, and the cell undergoes apoptosis, programmed cell death.
Irinotecan has a particularly nasty side effect profile, right? Diarrhea.
Yes, irinotecan is infamous for causing severe diarrhea. And you have to know there are two distinct types.
Two types?
Yes. There's early onset diarrhea. It happens during or shortly after the infusion within 24 hours. It's caused by a cholinergic effect like stimulating the parasympathetic nervous system.
How do you treat that?
With atropine, it's usually manageable. But then
Where's the other one?
Then there's the delayed onset diarrhea. This happens days later, typically 2 to 10 days after treatment. It can be incredibly severe, persistent, leading to dehydration, electrolyte imbalance. It can be life-threatening.
How is that managed?
Aggressively, usually with high-dose loperamide way beyond the standard OTC doses, following a strict schedule until the diarrhea stops. Fluid replacement is critical. And importantly, patients on irinotecan should absolutely avoid concurrent laxatives or diuretics.
That makes sense. Don't want to worsen fluid loss. Okay, final CCS class, antineoplastic enzymes. This sounds different.
It is quite different. The main examples are asparaginase and its longer-acting form, pegaspargase.
How do they work? Not blocking DNA or mitosis.
No, they work by starving certain cancer cells. They are enzymes that catalyze the breakdown of the amino acid asparagine into aspartic acid and ammonia.
Why does breaking down asparagine kill cancer cells?
Because normal cells can usually synthesize their own asparagine if they need it, but certain leukemic cells, particularly in acute lymphoblastic leukemia, ALL, lack the enzyme to make their own asparagine. They rely entirely on scavenging it from the blood.
So the drug destroys the external supply.
Exactly. Asparaginase depletes the circulating asparagine, and the leukemic cells that can't make their own are starved of this essential amino acid and die.
Clever.
Yeah.
What are the unique side effects here? If it's targeting an amino acid, what goes wrong?
The main unique toxicity relates to impaired protein synthesis in normal tissues too, particularly the pancreas and liver. This can lead to impaired pancreatic function. Meaning potentially severe or even fatal pancreatitis. That's a major warning. Also hyperglycemia because insulin production can be affected, and sometimes coagulation abnormalities.
Okay, that covers the four main CCS classes. We've hit the mechanisms, the toxicities. Now, let's bring it back to the bedside. Successful chemo isn't just about picking the right drug. It's about managing the patient through it. This really puts the focus on comprehensive nursing care.
Absolutely. It's not just administering the drug. It's active risk management. It's anticipatory care.
So on the assessment side, what are the absolute must-dos?
Continuous, vigilant monitoring. You're tracking all the labs, RBCs, hemoglobin, hematocrit for anemia, platelets for thrombocytopenia risk, and critically, the white blood cell count with differential, especially the absolute neutrophil count, or ANC.
Watch for neutropenia in that nadir.
Precisely. And you need to assess for signs of infection constantly. Fever is key. A temperature over 100.5 Fahrenheit or 38 Celsius in a neutropenic patient is considered an emergency until proven otherwise.
Right. Assume infection. What else?
Assess for symptoms of anemia, fatigue, pallor, shortness of breath, hypoxia, and signs of thrombocytopenia, bleeding gums, nosebleeds, petechia, bruising, blood in stool or urine.
Okay, that's assessment. What about critical nursing interventions in patient teaching? Managing infection risk, for example.
Strict hand washing by everyone, patient, family, staff is number one. Teach the patient to report any fever immediately. Avoid crowds, people who are sick.
What about those WBC stimulants like filgrastim? You mentioned timing earlier.
Yes, crucial point. Drugs like filgrastim or pegfilgrastim stimulate WBC production. They should generally be administered at least 24 hours after the chemotherapy dose is completed.
Why the gap?
Because if you give the stimulant while the chemo is still active or just finished, you basically stimulate the bone marrow to produce new cells that are immediately killed by the residual chemo. It's ineffective and could potentially even worsen myelosuppression. The timing matters.
Good to know. What about managing the GI side effects? Nausea, vomiting.
Premedication is key. Give antiemetics 30 to 60 minutes before starting the chemo infusion, not waiting until they feel sick. Proactive. And advise patients to avoid things that irritate the GI tract, spicy foods, acidic foods, maybe high fiber during periods of diarrhea, definitely alcohol. Small, frequent meals can help too.
And for the painful mouth sores, stomatitis, what's the advice there?
Gentle oral care is essential. Use a soft bristled toothbrush. Rinse the mouth frequently, plain water is fine, or a mild saline baking soda solution.
What should they avoid?
Critically, avoid commercial mouthwashes that contain alcohol or hydrogen peroxide. They sting, they dry out the mucosa, they make it worse. Lemon glycerin swabs, too, also irritating.
Okay. Gentle rinsing, soft brush, avoid irritants. Finally, a really crucial safety area that impacts the patient's future. Reproductive health.
Yes, this is non-negotiable counseling. Many chemotherapy drugs are highly teratogenic. They can cause severe birth defects if pregnancy occurs during or shortly after treatment.
So contraception is vital.
Absolutely essential. Reliable contraception must be used by patients of childbearing potential during treatment, and for a significant period after treatment ends, often advised for up to 8 weeks or even longer, depending on the drug and guidelines, for both men and women undergoing treatment.
And what about the risk of infertility?
Patients must also be counseled on the risk of permanent sterility, which is significant with many chemo regimens. Sperm banking or egg freezing options should be discussed before treatment starts, if possible and desired.
That's a lot of critical information. Okay, let's try to recap. We've covered a huge amount today. We defined the challenge, that low therapeutic index. We identified myelosuppression as often the dose-limiting toxicity and that critical nadir period. And we broke down the mechanisms and unique dangers of the 4 major CCS classes. The antimetabolites, those S-phase saboteurs.
Like methotrexate with its leucovorin rescue.
The mitotic inhibitors, breaking the cell's skeleton in M phase.
Like vincristine with its neurotoxicity and that critical intrathecal warning.
The topoisomerase inhibitors, snipping DNA strands in S phase.
Like irinotecan and its 2 types of diarrhea.
And the antineoplastic enzymes, starving specific cancer cells.
Like asparaginase and the risk of pancreatitis.
Plus the essential nursing care for managing all those toxicities.
So here's a thought to leave you with. We're seeing this big shift in oncology towards highly targeted therapies, TKIs, monoclonal antibodies, drugs designed for specific mutations. They promise less toxicity.
Right, the smart bombs.
Kind of. But given this trend, how do these traditional, often brutal, but still highly effective CCS agents continue to fit in? They remain the backbone of many curative regimens. They are still the heavy artillery. How does their role evolve as targeted therapy advances? It's a foundational tension in cancer treatment that's definitely not resolved yet.
That's a great point to ponder. Thank you for joining us for this deep dive. We really hope this knowledge helps you feel well-informed and prepared.
And from the Last Minute Lecture team, thank you for learning with us.